Welcome to the Bend Don't Break podcast. We are powered by The Source, Ben's locally owned media company and weekly newspaper. This podcast is our eddy in the rushing waters of local journalism. We are glad that you are taking some of your time to listen to us chat with the people who shape our local community. Support us through our member program at bensource.com.
Thank you to our presenting sponsor, RE/MAX Key Properties, a family-owned full-service real estate brokerage specializing in residential, luxury, commercial, new construction, and ranch and land properties. Their new state-of-the-art facility at 42 Greenwood Avenue is a modern, collaborative space and the new home of the Bend Don't Break podcast recording studio.
I'm Aaron Switzer, publisher of The Source and producer of this Bend Don't Break podcast, along with Megan Burton, who is off screen and being blinded by a very bright light today. Today, we are joined by Kat Mastrangelo.
Correct.
Executive Director, rhymes with Michelangelo.
That does.
Executive Director of Volunteerism Medicine, the free clinic serving uninsured adults across Central Oregon. Kat has spent her career working in healthcare, public policy, and community leadership and has guided VIM since 2008 after first starting as a volunteer. Her work has earned national recognition, including the Circle of Caring Award from the National Association of Free and Charitable Clinics. Kat has lived in Bend for 20 years and serves on several local and national boards, including NAFC, CASA of Central Oregon, City Club of Central Oregon, and the Central Oregon Health Council. We're excited to welcome her to the podcast.
Thank you.
And full disclosure, I also serve with Kat on the programming committee for City Club, now the board.
Yes.
And it is fun. It is a ton. We have a lot of fun.
Put a little pitch out there for City Club.
Yeah, and Kat is a very good programs lead. Put that on in the thing as well. So, Kat, thanks for joining, and maybe just start by talking. You've been here for 20 years, but what's the story prior to that? How did you? Where did you start out?
How did we end up? Huh?
Yeah, how did you end up here?
Oh my gosh. Well, like everybody else, I mean, it's such a beautiful place, right? Now, I grew up in Mississippi and met my husband in college on the East Coast. And after much moving around the Midwest, back to Baltimore for a little while, then to Kentucky, he got a position here.
Yeah.
And I'll tell you, 20 years ago, when we came out, a little over 20 years ago, looking for houses, one of the questions you got then was, oh, you're moving here. Do you have a job already? Or are you going to look for one when you get here? Yeah. And we always found that very puzzling. Like, how could that even be a thing?
Right.
But we're really glad we landed here.
The Mississippi does not come through.
Yeah.
And I'm originally from Atlanta, and so I'm familiar with Southerners losing their accent along the way. But Mississippi, that's a heavy syrup.
Well, yeah, I could go back to it if you want me to. But maybe we'll save that for the margaritas later.
I usually can pick that up pretty well, but I did not hear Mississippi. So So what did your so you followed your husband's career here? What had you been doing? Where were you prior to moving here?
Yeah, so just prior to here, we were in Kentucky. And that's where our youngest child was born. But before that, we were in Baltimore for a year. Yeah. He did a fellowship there. And then before that, we were in Peoria, Illinois for 5 years. And so so before that, we were in Indianapolis. And that's where I finished my master's and went into health policy it was Blue Cross Blue Shield of Indiana, which has turned into Anthem. So many people have Anthem health insurance now. So I worked on physician reimbursement pricing there. And then from there, when we moved to Peoria, I first worked in the city manager's office and rotated through all sorts of different departments, including emergency services and public works. And then after that stint ended, I went to work for they had two big hospitals in Peoria. And so I worked at one of those.
There's nothing in your background, though, that would say small mountain town on the West Coast prior to landing here.
Well, and
how does Bend show up on your radar?
Well, when Mike was finishing residency and go anywhere. We got a big map out, and we just put pins in all the different places we liked. And I've always loved mountain towns. Yeah. So Asheville, North Carolina was one of the ones. Yep. And then
sister city.
Yeah. And then this was back when, there was no online job postings. So literally in the back of the journals, there would be job postings. Right. And there was one for Bend, Oregon, and we looked it up, and I thought, oh my goodness, that place is so isolated. I don't know. Right. And my husband convinced me to come out and look at it. And, literally we flew into San Francisco, and there was a meeting there, and we drove up, through 97 all the way up. Yeah. Saw the big, guns, ammo, liquor sign with the bear holding the fish. Yeah. Right. And I thought, oh my goodness, where are you taking me? But then we rolled into Bend, and it was, within 20 minutes, we were like, we looked at a lot of places, and this was really neat.
Oh, that's great.
So we had some friends out here in Oregon already, kind of over on the coast and up in the valley, but we love Bend.
And you've been at Volunteers in Medicine since 2006?
2004. I started as a volunteer when the clinic first opened, and I worked at the front desk, and I made appointments, and I helped people with their financial screening that we have to do for all our patients. Okay. Going back to when it very first opened. Yeah,
and maybe I'm not the only one, but I do suffer from the ignorance of thinking, this Volunteers in Medicine is Doctors Without Borders.
A lot of people they ask if we do international trips, and no, we don't, because there are a lot of people who need help right here in our community, and it's really neat because a lot of people we are not affiliated with any sort of church or anything, but a lot of people do come to us out of that sense of mission, and they are very grateful and appreciative that there's an opportunity like that here. So in our own backyard, we can take care of people. Yeah.
So give me the, 101 on Volunteers in Medicine here locally. Yeah. What are the services?
So we are a free clinic, so that means that we do not charge anybody for the services we provide. And our main program is obviously primary care, so people just needing a doctor, like a family doctor. But then we also have retired specialists who will volunteer, so we can do a lot of referrals to specialists within our own clinic. We also have one of only 3 charitable pharmacy licenses in the state. Wow. And so we can get donated medications. So almost anything a patient would need that would be prescribed, we are able to get through our charitable pharmacy at no cost.
How does donated medications work? Right. Can I clean out my cabinet? Here's some benzos I wasn't using today.
So when we first started this, and that's going back about 12 years now, the state did allow us to accept donated medications from individuals. Wow. It still had to be in the original sealed container. And so, if you had just gotten a prescription at the drugstore and it was in one of those little pill bottles, we couldn't take it. But the ones that were still sealed, we could. And, we had some really expensive medications, like some of these, like rheumatology meds that are, $10,000 a dose. Wow. And grandma would pass away and they would have extra and they would bring it to us. And then probably about 5 years into that, they had a change of heart and did not allow us to do that anymore. Yeah. But originally we were getting medications. It was somehow on our website. And so people from all over the country would send us medications. There was a form they had to fill out, an affidavit. But North Carolina, Texas, Massachusetts, we would get boxes every week of meds because it's people really want to be able to do that, and we can't anymore. So the donated meds now come from the pharmaceutical companies. Okay. Or there are 2 big companies, AmeriCares and Direct Relief, and they kind of collect a lot of these medications at the manufacturer level if they kind of are on short label or whatever. And then they will distribute that to the free clinics. And so we participate in those programs.
Yeah, all kidding aside on that kind of thing, it's an incredible boon to be able to take these medications that otherwise would be destroyed and redistribute them to people who obviously aren't going to be able to afford some of these prices.
Absolutely. And, the value of the medications, it's $2 to $3 million a year that our patients receive in donated medications. Wow. through that program.
Yeah.
Now, we can't have anything like narcotics. Our pharmacy
Sure.
does not. We don't have that type of certification, but everything else we are able pretty much to do for our patients.
Yeah. And at the backbone of this is practicing physicians or retired physicians who are donating their time to see the greater community.
Yes, doctors. So we have MDs and DOs. We have nurse practitioners, nurses, pharmacists, physical therapists, counselors, anybody with a professional license who wants to volunteer. And if we have a need, we can match that up, which is pretty cool.
Yeah. And how large is the group of volunteers in that field?
Yeah, we've got about 150 total volunteers, and probably 40 to 50 of those are doctors, and another 40 to 50 are nurses, and then another third are, whatever. A lot of interpreters. We need a lot of interpreters, people that can work at the front desk, people who help us with our fundraising, all sorts of different jobs.
So how do you, I don't want to use the word screen, but how does someone avail themselves of your services? How do you determine need? Things like that.
That's a really important program for us because we have this charitable pharmacy.
Right.
Those pharmaceutical companies are pretty strict about who they're going to give medicines to, as you might imagine. So we have a pretty rigorous screening process, and it involves bringing in either pay stubs or tax returns. And then we have to certify that you live or work in Deschutes County or Jefferson or Crook counties. Excuse me. And that you've been here at least 90 days. Right. And let's see, what is the other piece of that? Oh, somebody in the household does need to be working. So it's a program for people who are working. And our income guidelines go up to 300% of the federal poverty level. So for a family of four, that's I think it's about $65,000.
Okay.
So we're not, the people who are really low income are going to qualify for OHP.
Right.
So we're kind of the people that make too much for OHP, not enough for being able to afford insurance, and their jobs generally do not provide it.
Yeah. That is fascinating. Do you have waiting lists? Are you meeting the need?
Right now we are meeting the need because in Oregon we expanded OHP. So when they expanded OHP, a lot of our patients were able to qualify.
Yeah. Brilliant.
And so then we've built it up. We have more people who have found us now. We right now do have room, which is one of the reasons we want to get the word out, is that with all I'm sure you're going here with this conversation, right. But with the subsidies expiring, we are really anticipating a lot of people are going to realize they cannot afford insurance anymore.
Right.
And they're going to be out of luck on what they're going to do.
Yeah, I don't know how media and understanding of what it means when the insurance is cut, and the cost goes up, but I haven't seen the kind of panic that I expected to see with regard to the numbers that I've seen. The numbers that I've seen with regard to how much people are going to pay and how much those costs are going up without, usually there's some kind of, I think, we're working on it, or it's pretty much just, it's happening. So was one of the reasons I wanted to bring you in for the podcast. What are you experiencing on your end as you anticipate catching some of these folks? Yeah,
so the people that answer our phones, we have definitely seen an increase in the number of people calling and wanting to know about services. A lot of them are, this is interesting too, a lot of them are actually on Medicare. And the Medicare premiums for the Advantage plans are going up. And so they're really...
Well, they discontinued the Advantage
some
plan.
Some of those too,
my parents were in the situation where they moved from Advantage to a different, and all the panic that went in with that.
Right, and so they're really worried about, especially the cost of medications. Right. And Part D has gone up really high. Right. So they are calling to see if we might be a resource for them. And unfortunately, we cannot take care of patients who have Medicare or Medicaid. We are only for people without insurance. Yeah. And so that's it's. But
it seems like that's the population that's going to be most impacted.
Oh,
that in between group.
Yep.
You know.
Absolutely, and I think we're not going to see the full impact of that on January 1 because the subsidies expire December 31st.
Right.
And so come January 1, some people are going to be really worried about it because they're in the middle of something right now and they're trying to get the care they need. And I think what's going to happen is a lot of people who, if you're in your 30s or 40s and you don't have a lot going on, you may be like, oh, I really need that, but I'm okay right now. I'm just not even going to worry about it.
Yeah.
But come March, April, May, and something does come up and you're like, what is that weird spot on my arm? Or, what's going on with my hip? That's when people, I think, are going to start to be looking for what am I going to do now?
Yeah.
Yeah.
Yeah, you bring up a good point that it could be this population that, I remember when I was in my 30s, you're between jobs, you're debating whether you're going to get your own insurance and you don't qualify for this. And certainly at those early stages when you're starting your career, your employer probably isn't picking up or may not be picking up your insurance. But it's not the kind of thing that sparks any kind of urgency until you go in. This just happened to my son, actually. And the doctor presents him his first bill. And you're like, wait, my wage is never going to cover this kind of care.
Right.
And I don't think that a lot of people have that. Now, like you've been down the road as much as I have. Yeah, you're going to look back, you know what's coming, but I do get the sense, because I kind of mentioned it, is I have this, for me, it seems like such a major, problem that I just haven't seen the panic. But now it does make a little more sense that it's in a population base that probably thinks they're going to be okay.
Or they're just crossing their fingers that they're going to be okay, right? And they'll just keep playing the lottery and hope it all works out.
Yeah.
And it will for a while, and for a lot of people it will. But that's part of how the ACA was structured, was with everybody participating. That meant that it was less expensive for everybody. And if people start to opt out, and especially the healthy people, that leaves the people who are less healthy in the system, which means they have a higher spend on their health insurance, which means that the insurers need to charge more for those premiums. And as a small, we're a small business too, Volunteers in Medicine, we're a nonprofit, but we just got our premium updates for starting in January. And oh, wow. It was a big shock. I had budgeted a little bit of an increase, but not nearly enough. And we are ending up having to go with a higher deductible on our plan that we offer our own employees. Right. Just to be able to afford it.
Yeah, we're going very similar story at our company. It's definitely not a great year for insurance.
Right. And that will impact people. We talk about like inflation and just the cost of going to get groceries, but down the line, if you're paying $75 for a doctor's visit instead of $50, and you have to pay the first $5,000 instead of $2,500, you don't feel that immediately, but over the course of the year, that really does add up.
Yeah. What do you anticipate is going to happen with the insurance companies' roles and responsibilities in this shrinking environment? Because it's one thing when insurance companies do have ACA, and I remember, for those who can remember or followed it, those were big titans fighting as the ACA was going through. And they did, ultimately the promise was to drive all these people in. But there were, there's been history of pre-existing conditions. So these people don't pay these. Now they lapse. Now they discover they've got a condition. Yeah. And now they're going in and the premium is much higher. And it was always in their court, in their favor. And I feel like that's another aspect of this that we're not hearing a lot about.
And that was one of the most popular pieces of ACA. Yeah. There were two pieces that were really popular. Number one, you could keep your kids on your own plan until 26. Right. Huge. But the other one was the pre-existing condition. So you weren't stuck with the plan. You could move jobs. You could get a new plan if you needed to during open enrollment, and your pre-existing condition would not be excluded, because that's how those policies used to be written. Yep. And that's huge. That is so huge for somebody who is dealing with something, and especially chronic disease, diabetes or high blood pressure or lupus. All these different diagnoses you can get, which is why you want to take care of yourself. Right. if that is not covered under care, then that is really hard.
Yeah, and because, I mean, it's something that they're paying on a regular basis and also have paid into the system up to that point. And by system, I mean the insurance company, not the social safety net or any of that. But you paid this company quite a lot of money.
Yeah.
And now, due to, because these premiums are going up and whatever the machinations are behind their bottom line, you've been dropped. Now you got to go, maybe you let it lapse for a year and you realize I got to get it. And now you're going in and they're bringing up your old medical records.
Right. Well, and the way
it's insane.
The way insurance companies are set up and some of the legalities around it, they expect to be able to have a 20%. They expect that the cost of care that they are paying for is 80% of what they get in premiums.
Okay.
And so then there's 20% for the admin and all the other pieces. They have to spend at least that much. Now, some of them end up spending more than that, 85%, sometimes even 90%. When you start to get much lower than that, then all of this infrastructure that the insurance companies had, they can't make the dollars work. And so that's part of what we're seeing in Oregon is several of these companies that are CCOs now are they're beyond those margins that they're expecting to get. And so they are actually losing money on caring for people. And part of that goes into, it's utilization in part. And a big piece of that is the pharmaceutical companies who are still making a lot of money. Yeah. And if we can either not let people have access to treatments, or we could look at different ways to how do people get reimbursed for their care. Yeah. I
mean, I think it's fair to say I was a fan of the ACA. I would have liked to see that trend continue. Mm-hmm. I just, in the vacuum, it does not seem to me right now that there is going to be some way. To me, there have always been like negotiating government entities, which for a journalist is the only way I could really wrap my head around it. But they're not at the table. They're all they're all siloed at this point, and I don't see how that's going to benefit. That's going to benefit the general population because you got to have an arbitrator.
Yes, you do, and you need to be able to buy in volume, right? Mm-hmm. So, one of the concepts that's floating out there is let's just give people the money, and then they can go get their own health care. Well, if you don't have any purchasing power and you're just going as an individual who's under some duress because you're sick, you're just going to pay whatever they ask, or you're just going to say, I can't afford it. Instead of, here's somebody who does this for a living, and we know we're going to have X number of hips we need to fix and X number of, whatever, diabetic patients, and we need to work to get that volume pricing down. Somebody compared it today that I heard, you go to Costco, you buy a membership up front to be able to shop at Costco. But when you go to Costco, the people who run Costco have done the work for you. Right. They have gotten the lower prices within the warehouse so that when you go in and shop there, you get that benefit. Yeah.
Do you see for volunteers in medicine in particular, where are the bright spots? Yeah. As we move through this.
I mean, I'm smiling because, we talk about volunteers, we're like this little island, right? Yeah. Because everybody who's coming to work there and take care of patients, they're there because they want to be there, right? Yeah. They're volunteers. Right. They get just paid with smiles. And the bright spot, I think, is that a lot of people who go into healthcare, they go into it for the right reasons, which for me is because they want to give back. They have talents and skills, and they want to help other people. And they've spent a career in healthcare, and they've dealt with terrible schedules and not getting pay raises and not feeling appreciated and everything else. And they retire and they come to VIM, and they are just doing it because they love being there with other people who are caregivers, and the patients are so appreciative. So I would say our volunteers are the number one bright spot that we have. But then also the patients, because instead of feeling like, you have to do this because you're getting paid for it, there's this other piece of it, which is you're here and you're doing this out of the goodness of your heart. And I want you to know how much I appreciate that, right?
How do people find out about volunteers in medicine other than this great
This podcast. Yeah, this is it.
Right.
Most of our patients now, it's word of mouth, honestly. And you can imagine if you were going to go to a free clinic, you might be like, oh, I don't know about that.
Right.
But if you have a friend or a relative who goes there and they're like, no, actually, it's a really great place and I love going there and the doctors are terrific, then you have a lot more confidence.
Yeah.
And I think a lot of people, for a long time we had a waiting list and we just were at capacity. And so we didn't do a lot of outreach. Now that Oregon has stepped up and really expanded who is eligible for OHP, we now do have capacity. And, we're really hoping that in this transition, we can be a place for people who are out there who can't afford their premiums anymore, who meet our guidelines, will be able to find us and at least have a medical home till we can get all this figured out.
I know you can't look in the crystal ball, but do you think that OHP is going to hold with all of the funding cuts?
Yeah. I hear different things.
Yeah.
So, depending on, what happens with the kicker and what happens during the short session, I can't imagine if things don't shift at the national level. Right now, our Medicaid waiver is good for another year or two. Once that runs out under the current administration, I don't think there's any way that will be extended. And so I think that will be our real reckoning point is if something hasn't shifted, that's when we're going to really be in a world of hurt. I have heard some talk, years ago, Dr. Kitzhaber, when he was governor, he came up with the whole
Helps having a doctor.
list. Yep. He had that whole list, and we said, we will fund everything in the state. We set it up 1 to 7,653, right? Number 1 was prenatal care and deliveries. And at the bottom were things like, and they would set a line. And so everything above this line we will cover. And if we don't have enough money, everything below the line, we don't have money to do it. Right. And so things like an elective hernia might be below the line. It could benefit you. There's definitely reasons to do it, but you're going to be okay. And that's how we used to operate our OHP. Well, in the last year or two, that was determined not to meet the Medicaid standards. And so now we are not able to use that list and that line anymore. So to cut benefits, we can't just put a line on the sheet.
Right.
We have to then just say we're not going to cover whole parts of care that Medicaid would let us shift.
So the line isn't moving up and down that any longer?
Nope, it's the same thing for the country now.
Yeah.
Yeah.
Well, Kat, that is at the end of our time here for the podcast.
That went fast.
I know. That's.
I could talk about this stuff forever, And I really do hope, though. I mean, if you or somebody does not have insurance, or they're in this situation where the premiums are going way up, you should go to our website. We're getting some information put up so people can easily see if they might be eligible, and if so, that we want to be able to help them.
Yeah, I have a feel. I mean, again, I mentioned as previously, I just have a feeling, and maybe it's going to take 2 years for the water to really start boiling on this. But it's getting warmer, and I do think that, access to services and groups like yours, and it's the philosophy behind it, if there is a philosophy, is to try to drive more individuals to participate in programs like this. It wants people to volunteer. I mean, that's the only way I can philosophically see the gap, is that if people start putting their time and their charitable resources towards these type of things where there's a gap, or I don't see the two meeting.
Well, and the neat thing about when people donate to VIM, because it's also December and the year time, what's neat is the dollars that you donate to VIM really get leveraged because of this volunteer piece, because of our charitable pharmacy. That's one thing I really love about when people make investments in our clinic, is that it's not just, it's going to direct services, but it's also getting multiplied by this volunteer spirit.
Great. Well, Kat, thank you for coming in and rapping with us.
All right. Thanks, Alex.
This has been the Bend Don't Break podcast. If you liked what you heard, you can go to bensource.com, become a member, and donate to help us bring more folks in like Kat, and also do be generous and keep them going.
Yes.
All right.
Thank you.
Thank you. You've been listening to the Bend Don't Break podcast, powered by The Source Weekly. To read, hear, and see more of what we do, go to bensource.com.